So, all right, Albert, you're back up again, my man. So, hopefully we don't have any of these injuries tomorrow, right? Right?
I was thinking about that when I was preparing to talk, and I was knocking on wood a lot. But yeah, that functional gap thing. That was really impressive. That's really cool stuff. So thanks for bringing that to our attention. So I'm going to talk about posterolateral corner injuries. These are interesting injuries. These are challenging injuries, and we'll just kind of fly through it here. The first thing I want to show you is this video, and they'll show it a couple of times in slow motion. It's a little bit gruesome, honestly, but so this happened a couple years back. And you can kind of see it in slow-mo a little bit better. This was Marcus Lattimore, who was a pretty highly touted running back for the Gamecocks. And he had this pretty fearsome injury, this knee dislocation. And you could see that the defender came and hit his planted knee kind of from the medial side, and you had probably a hyperextension valgus type mechanism. So first and foremost, posterolateral corner injuries of the knee are bad injuries. Fortunately, they're not terribly common. The majority are combined with other ligamentous injuries, and so they're in that spectrum of multi-ligament injuries versus and knee dislocations. Depending on what series you read, there's a very few of them that are isolated, just posterolateral corner injuries. The mechanism is that hyperextension and varus force. It could likely be a posterior load, like a dashboard type injury from a car accident as well. There's some other pictures of folks that have had injuries similarly on the football field. The big thing to remember about these injuries is that they're a diverse group of injuries. They're very heterogeneous because they can occur with different ligament injuries, associated ligament injuries, and they can be caused by different mechanisms. That football injury is technically considered a low energy mechanism, and the high energy mechanisms when it comes to these posterolateral corner injuries are ones that you see in car accidents or motorcycle crashes we commonly see. I see a decent number of these because I work at Harborview Medical Center, which sees a lot of high volume kind of level 1 trauma. And because of the extent of these injuries, they're oftentimes associated with vascular injuries or nerve injuries about the knee, and they can obviously also be associated with life-threatening injuries elsewhere in the body. So that complicates the whole picture. And again, since this is such a diverse group of injuries, there's not a lot of great data. When you try to study these injuries, they're not like all apples. It's hard to compare them all together and make some kind of reasonable conclusion. Dr. Frank did a great job of talking about the anatomy, so I don't think I need to go too much into this, but she talked about the posterolateral corner, and I did borrow from Jorge as well, who, and again, Dr. LaPrade has a huge footprint in this area of research. So we're talking about the FCL, the popliteus, and the pop fib ligament, which are the three main stabilizers of the posterolateral corner that provide varus stability and as well as external rotational stability, meaning that it resists an external rotation force of the tibia in relation to the femur. For the clinicians and surgeons in the room, you have to remember that these are oftentimes high energy injuries, so you got to think about your ATLS if you see them in a trauma bay. For us sports docs, we're not so much in the trauma bay anymore, so it's not really a concern. I thought this was funny because one of my partners at Harborview, I don't think this is funny, but they sent me this picture just a couple of days ago, so I put it in my talk, and he said, "Hey, I think I got a multi-leg knee for you." And I was like, "Yeah, I think you do." And I would challenge anybody to find the patella in either the clinical picture or the X-ray. I don't know where that went. So anyway, so these can be very challenging injuries. And like I said, they're oftentimes associated with vascular injuries, so it's something that you need to be aware of. Again, this is something that's probably going to be worked out in the acute setting in the trauma bay. Some of the research that came out of Harborview along those lines identified that if the patient has some oddity of their pulse exam, that you should go to an ankle brachial index, which is comparing blood pressures in the arm versus in the leg. And if you have a ratio that's less than 0.9, then you should take that patient to angiography. In this day and age, it's CT angio because it's nice and quick, and you can identify if they have a popliteal artery injury. It occurs somewhere between 3 and 32% of the time with these knee dislocation type injuries, and it's been found by the Mayo Group that if you have an arterial injury, you're going to have a worse functional outcome, which just kind of makes sense to me. Oftentimes when you have an artery repair in conjunction with a knee dislocation, you're going to have 4 compartment fasciotomies of the leg, either because you have compartment syndrome or prophylactically, and that will affect your outcome as well. They're also associated with common peroneal nerve injuries, especially the posterolateral corner injuries, more so than any other type of dislocation. Occurs somewhere between 14 and 40%, Recovery can be variable, somewhere between 30 and 75% of the time, and sometimes it comes back fully, and sometimes it comes back partially, and sometimes not at all. Interestingly, again, the Mayo series showed that that doesn't always correlate with poorer outcomes. And I showed you that picture of Dalen Smith, who dislocated his knee or had this bad multi-leg injury during his last college football game. And after 2 years of rehab and surgery, it looks like he's back on the field and he's playing pretty well for the Cowboys. I think if you squint, you might see that he's wearing some kind of an AFO because he had a nerve injury as well, which it looks like has not come back completely, so that's pretty impressive. He's obviously a specimen, though, so that's probably different from you and me. Dr. Frank talked about all the exam things, so I'm not going to belabor those, and she showed a nice picture of somebody having this varus thrust. This video doesn't show it great, but she has a right knee posterolateral corner injury, so you can see that as she starts to plant, that knee goes into varus. Some other specialized tests. The external rotation recurvatum test, you just pull both toes up and extend the knees, and the side that has a posterolateral corner will go into varus and external rotation, and you'll see that as recurvatum. The dial test, which can be done either supine or prone, and you're comparing two sides, externally rotating the tibia and seeing if you can see a more than 10-degree difference side to side. At 30 degrees, it indicates that you have a posterolateral corner injury. If you have an increased dial at both 30 and 90, then you have a combined injury with the PCL. This is a test that one of my mentors, Bob Marks, taught us at special surgery, and this is what he called the posterolateral spin test. So he takes the knee to about 90, and he puts this external rotation force on the tibia, and you can see that the tibia goes back because this patient has a grade 3 posterolateral corner injury. And normally that tibia, like we found earlier, should be anterior to the femoral condyles, and this thing goes way behind. Imaging, I won't belabor as well because we've talked about all that, but you get standard x-rays. Dr. Laprade has done a great job informing us about the importance of stress radiographs, and you can look up some of his papers on what the values are before you have certain types of injuries or certain grades of injury in the posterolateral corner. For chronic injuries, alignment is of concern. If you're going to reconstruct them, you have to make sure that you don't have malalignment, and so full-length standing films are important as well. And MRI is kind of the standard for imaging because it allows you to see so much of the knee, what's going on with the meniscus, the cartilage, any other associated injuries. Treatment options, I think we've kind of thrown non-operative care out the window because they've done a lot of studies and it shows that you just have poor outcomes with any kind of multi-leg knee injury if you just treat them non-operatively. But there's the occasional patient that is just a terrible surgical candidate, and sometimes we'll treat those non-operatively. Obviously, X-fix is not, in the truest sense of the word, a non-operative procedure because you usually have to take them to the operating room to put one on. But it's interesting, I've had several patients that come from Harborview in an X-fix because they're not able to reduce them and keep them reduced in a brace. So my colleagues over there are just magicians when it comes to fractures. So they get this knee aligned, and then what I do is I usually take the X-fix off in the OR at about 4 or 5 weeks after the injury, and usually they're still reduced. They're stiff. I give them a gentle manipulation, and then I examine them, and the ligaments aren't bad, honestly. And I used this for a couple patients where I thought, like, hey, these are not great candidates, and they've actually done okay. So there's something to that, and we're actually going to kind of look in to see if there's something specific about those patients that allows us to do that. Timing of the surgery has been debated, whether we should go in early or wait until the soft tissues have calmed down. I would argue for earlier, and I think that in general, people who are taking care of a lot of these are saying now that earlier is probably better. The tissue planes are still preserved. The tissue is still usually identifiable. If the quality of the tissue is good, you can do a repair, which is really nice. And this was an 18-year-old gal who had dislocated her knee playing soccer, and you can see there's a big avulsion off the fibula and proximal tibia. We were able to repair all that. I was actually able to repair her PCL through a couple bone tunnels after I put stitches through it, and then I reconstructed her ACL. The question was, do you get better results by going early? Again, we don't have great data. This is a systematic review looking at several level 4 studies, and they found that perhaps there's improved Lysholm score in that early group, but it's not super convincing. Same thing for IKDC. This is the % of patients that had good to excellent results in these series. Now, these series are kind of dated, so this is a newer study, but again, there's only so many case series to systematically analyze. This is, again, out of Laprade's group. And they looked at a bunch of different reconstruction techniques. There are ones that are just what we call fibular-based, with one tunnel through the fibula and one graft, and Dr. Laprode's, which is 2 tunnels, one in the tibia and the fibula, and are considered more anatomic because you're basically reconstructing every part of those 3 main ligaments or structures that we talked about in the anatomy. His study was 8 studies, 134 patients. Part 1, you'll see here, these are acute injuries, various surgical techniques that I showed you. The biggest finding, if you repair the posterolateral corner and then you wait to stage the cruciates, you're going to have a high rate of failure. So that was the big message from that. He followed up, obviously, he would never do anything halfway. So part 2 was chronic injuries, 15 studies, 456 patients. Again, various surgical techniques, 90% success rate. I think this is minimum 2-year follow-up. To conclude, these are the structures that we cared about. We've talked about that. These are severe and challenging injuries. A good exam augmented with appropriate imaging is important. Be on the lookout for these vascular and neurologic injuries that are associated with them. Early surgery is likely better because the tissues are better, the planes are better. It's easier to actually find the nerve and do all these things, except when it's all early, and not late when it's all scarred down. And there's actually a randomized trial that we're looking at the timing of these injuries and how that might affect outcome. That's actually just about to start. We got some funding from the DoD that's based out of the group at Pittsburgh. Address all injuries in the same setting if you can. Reconstruction may give you slightly better outcomes at this point, and definitely more research is needed. Thank you.